extrovert will do? They are always expressive. They don't hide things. Whatever happens, they keep on expressing. Whereas this introvert, they always hide feelings and lot of relationship inside themselves. We can't predict what they're thinking. Similarly, if you're having an acute inflammation of the nose, you could easily find out what the patient is going through. If you are having chronic inflammation of the nose, you can't easily find out until it reaches some threshold. You made it clear, right? We can dive into our class. First, we'll start with the acute inflammations of the nose. First one is acute rhinitis, then allergic rhinitis, then vasomotor rhinitis. Now, let me explain these terminologies in detail. First one is acute rhinitis is nothing but normal viral coryza. It is nothing but the common cold that we will contract. We'll go slowly so that you will have adequate time for writing down the things. So acute rhinitis is nothing but the common cold, viral coryza. So how we are going to treat? We are just going to conservatively manage this patient by adequate hydration and proper reassurance that it will eventually settle down in another 3 to 5 days. It will settle down in another 3 to 5 days. You don't need some exaggerated treatment for this particular disease. Then, second disease under acute inflammation of the nose, allergic rhinitis. A patient comes to you with, see doctor, I'm always getting episodes of sneezing, serious discharge from the nose and nasal stuffiness whenever I get exposed to pollen, the fur of the dog and the cat. So these sort of dust, mite, pollen, if it stimulates type 1 hypersensitivity reaction, it is called allergic rhinitis. Type 1 hypersensitivity reaction, it is allergic rhinitis. Here it is IgE mediated. It is IgE mediated. Clear? So allergic rhinitis, you could see at least one allergic rhinitis case in every gang of friends, right? So what they will do, whenever they get exposed to small things, the first person to give a sneeze in that group will be that particular person. Okay. So allergic rhinitis, what are the signs that you could see? See, you could see some blackish discoloration below the eyes. You can call it as allergic shyness. Blackish discoloration over the nose. Allergic salute. Clear? So the patient comes to you with this particular history, you are eliciting these signs in this patient. So how you are going to confirm the diagnosis? In a long run, you could do a skin prick test. Okay, so you are taking the allergen, you are injecting into the skin of the patient subdermally. If it produces allergic type 1 hypersensitivity reaction, then it is skin prick test positive. Or else you can take a patch The patch is full of a lot of allergens. Like this. You can stick this patch over the back of the patient. Okay. Then you can examine which allergen among these patch has stimulated the reaction in this patient. So you are taking a patch. A patch will have approximately 40 to 50 allergens. You can stick the patch over the back of the patient, which will delineate among these 40-50 allergen which has been used, which allergen has been the culprit for causing allergy in this patient. These are the two important tests they may ask. Okay. So we have sorted out the signs, we have sorted out the important investigation. Now, the symptoms of the patient can be intermittent or persistent. Then the patient, apart from the symptoms, the patient can also have sleeplessness, affected routine daily activity, okay. So if the symptoms always present, it is persistent, it is on and off, it is intermittent. Then you ask the other symptoms, sleeplessness, and then whether the symptoms are affecting the routine daily activity of the patient. If this happens, you grade the patient as moderate to severe. If these symptoms doesn't there, only sneezing, nasal stuffiness, some basic symptoms are alone present, you can brand them as mild. Okay, so mild, then moderate to severe. In case of mild classified patients, you can try antihistamines. Then leukotriene antagonist. Then mast cell stabilizer. Clear? So if you brand the patient as the mild category of allergic rhinitis, these are the treatment. If you brand the patient as moderate to severe category of allergic rhinitis, you can try intranasal steroids, and then if it doesn't works out for a longer period of time, you can try immunotherapy. Immunotherapy is nothing but desensitization of a particular allergen to the patient. Immunotherapy is nothing but desensitization of a particular allergen for the patient. For example, if you are having allergy for a pollen or a dust mite, you could take that allergen, inject into the patient, make the patient become sensitive for that particular allergen. In this way, you are priming the allergen so that it has already get accustomed to that particular allergen. So signs of allergic rhinitis will not happen. Clear? You are priming to that particular allergen so that it is not happening. Okay. So you've seen about acute rhinitis, nothing but viral coryza. Allergic rhinitis, these are the points that you should be remembering. Vasomotor rhinitis. Okay, fine. Imagine you are in a marriage party. Okay, one girl has consumed some cold water, she contracted viral coryza. One guy already having repeated allergic episode, he is coughing, sneezing, so allergic rhinitis. One fellow, he was perfectly normal. Okay, when he got emotional at some point of time in that particular party, that emotional stuff has made him go symptomatic. See, for example, we as adults hardly cry on things. Okay, for instance, if we cry heavily for around 30 minutes, you just remember what will happen. We will have nasal stuffiness. Okay, we will have some serious discharge from the nose. Why it is happening? Because we are crying, our secretomotor pathway gets activated. Likewise, the parasympathetic stimulation also happening inside the nose and nasopharynx. So parasympathetic overactivity due to some emotional outbreak causing nasal symptoms, it is called vasomotor rhinitis. Is called vasomotor rhinitis. Okay, so if you get vasomotor rhinitis, again you should give some antihistamines. And then leukotriene antagonist. And if the patient keeps on getting such episodes, avoid emotional outburst. Avoid emotional outburst. That should be the advice that you will be giving to the patient. So I've done with acute inflammation of the nose. These are all extrovert. Now we are diving into chronic inflammation of the nose. Okay, so I am dividing chronic inflammation of the nose into local inflammation alone, local inflammation that has caused some granulomatous lesion, systemic causes causing some chronic nasal inflammation. Clear? So what are the local inflammation? So keeps on happening. Acute rhinitis, allergic rhinitis, vasomotor rhinitis, it keeps on happening. It will cause hypertrophy of the turbinates inside the nose, which is called hypertrophic rhinitis. It's called hypertrophic rhinitis. Then rhinitis sicca. Rhinitis gaseosa. Rhinitis medicamentosa. See, an inflammation which is happening for a longer duration of time, which is causing only local inflammation. Here there is no granulomatous lesion is happening, only inflammation which is keeps on happening for a longer period of time. So hypertrophic rhinitis, rhinitis sicca, rhinitis gaseosa, rhinitis medicamentosa. Now there are a few lesions where local inflammation for a chronic period causing granuloma formation. Okay, rhinoscleroma. Chronic inflammation causing lesion is Rhinosporidiosis. Okay, so chronic inflammation not causing granuloma, only few lesions, miscellaneous lesions are atrophic rhinitis, rhinolith, nasal meiosis. Fine. So seen about local inflammation causing lesion. Okay. Then we can dive into systematic causes that are causing nasal inflammation. Okay, there is an important part. First, sarcoidosis. Then Wegener's granulomatosis. Church-Strauss syndrome. NK cell lymphoma, cocaine induced inflammation. Okay, these are the systemic causes that are making changes inside the nose. Okay, fine. Now we can elaborate the things that we have delineated. Now we'll start with the chronic inflammation of the nose. First one is hypertrophic rhinitis. See, this is the nasal cavity. This is our inferior turbinate. This is the normal size of the inferior turbinate. If there is inflammation that is happening for a longer period of time, what will happen? This inferior turbinates will go for hypertrophy. Okay, so this is called hypertrophic rhinitis, hypertrophy of turbinates. Not only inferior turbinate, middle turbinate can also go for hypertrophy. Hypertrophy of turbinates. So if middle turbinate goes for hypertrophy, there will be nasal obstruction, but inferior turbinate hypertrophy is the bigger problem. Okay. Inferior turbinate hypertrophy is the biggest problem. So in hypertrophic rhinitis, you are getting inferior turbinate hypertrophy due to repeated episodes of rhinitis, which is acute rhinitis. It could be allergic rhinitis or acute rhinitis or vasomotor rhinitis. If it keeps on happening inside the nose, the physiological hypertrophy is creating a rhinitis called hypertrophic rhinitis. So if this happens, the patient will complain of nasal obstruction. The patient will complain of nasal obstruction. If the patient is having nasal obstruction, if he says that he can't breathe normally, what you have to do? You have to reduce the size of the inferior turbinates, which are hypertrophied. You're going to reduce the size of the inferior turbinates, which are hypertrophied. You could do cauterization, or cryosurgery, or cold steel turbinoplasty. You could do a cold steel turbinoplasty. Cold steel is nothing but using normal instruments without any heat. Okay, so cold steel turbinoplasty. These are the treatment options available for hypertrophic rhinitis. Okay, fine. A patient, a general practitioner, see, he sees a patient who repeatedly turns up to his OPD with the complaints of nasal discharge, nasal stuffiness. He very well knows that he is having allergic rhinitis. He always prescribes the nasal decongestant, okay, like oxymetazoline and xylometazoline. Clear? Oxymetazoline and xylometazoline. So rhinitis medicamentosa is repeated usage of rhinitis with nasal decongestant that is causing desensitization of the nasal mucosa to these nasal decongestants. So what will happen? The patient will have hypertrophic turbinates. So if the patient comes to you, what will you do? You could stop the drug. You could stop the drug. Then you could start an alternative drug like intranasal steroid. Start a drug like intranasal steroid. Clear? This rhinitis medicamentosa is an important MCQ point of view. They have repeatedly asked this question. You make note of this. Clear? So some one-liners: rhinitis sicca, rhinitis caseosa. Okay. So chronic exposure to dry air currents. Maybe the person is living in a high humid place or a tropical climate. So if there is too many exposure to dry air currents, the patient will get rhinitis sicca. If the patient gets cheese-like nasal discharge, it is called rhinitis caseosa. So the exact etiology for rhinitis caseosa is unknown. If you get these types of patient, you should try for nasal douching. What is nasal douching? It is cleaning the nasal discharge, that is obstructing the nasal airway for this patient. Obstructing the nasal airway for this patient. It's nothing but nasal douching. Clear? So these are the chronic inflammation of the nose without any lesion, just inflammation. Hypertrophic rhinitis, rhinitis medicamentosa, rhinitis sicca, rhinitis caseosa. Okay. The following are surgical procedures for hypertrophic rhinitis except radiofrequency ablation, laser ablation, submucous placement of silastic in inferior turbinectomy. See, I have told you, in one way or the other, you should reduce the inferior turbinate size. You could use a cryosurgery, you could use a diathermy, you could use a radiofrequency, you could use a laser, you could use a cold steel, but you cannot place a silastic prosthesis within the inferior turbinate. So this is usually not done for hypertrophic rhinitis. I'll come again. The idea is the turbinate size has been enlarged. You should somehow reduce the size of the turbinates. For that, you could try any method: radiofrequency, laser, or diathermy, cryosurgery. All these methods can be employed to reduce the size of the inferior turbinate. Whereas you can't place a prosthesis inside the inferior turbinate to reduce the size. Okay. An young man using xylometazoline nasal drops for longer period of time, what can be the possible adverse effect? So it is clearly rhinitis medicamentosa. So in the options, you like allergic rhinitis, okay, vasomotor rhinitis, okay, mulberry turbinates. So mulberry turbinates, this point is nothing but hypertrophic inferior turbinate. Nothing but hypertrophic inferior turbinate. Nothing but hypertrophic inferior turbinate. Clear? So this is the answer for this particular question. Now we can see a few miscellaneous disorders like atrophic rhinitis. See, inflammation keeps on happening inside the nose for a longer period of time due to a bacterial infection. So atrophic rhinitis is nothing but atrophy of the turbinates. Atrophy of the turbinates is called atrophic rhinitis. Okay, fine. So the causative organism mainly for atrophic rhinitis is Klebsiella ozonae. Okay, this is the most common bacteria. But recently they found out that few other bacteria like Coccobacillus, diphtheroids, Bacillus mucosus can also be the culprit in forming atrophic rhinitis. So if they ask in the MCQ, which of the following is not a causative bacteria for atrophic rhinitis, you should remember 4 of these bacteria for answering such particular questions. Clear? So Klebsiella ozonae is the most common cause for atrophic rhinitis. Okay. Mechanical theory of Zoufel is the pathogenesis. Okay. So what is the mechanism behind? So if This is the nasal cavity. The turbinates will get infected with bacteria. Gradually, the bacteria will infect the turbinates and it will produce greenish crusting, foul smelling discharge, and then roomy nasal cavity. Roomy nasal cavity. Just simple options has been given in 2021 INICET exam. Okay, these options are given, very simple options, but at that particular time you may think of other options. See, simple. In case of atrophic rhinitis, it is a bacterial disorder. It is causing atrophy of the inferior turbinates and also other turbinates also. Here there will be foul smelling, greenish crusting, and roomy nasal cavity. You just have to remember these 2 points for you to diagnose atrophic rhinitis. Okay, so there has been crusting that has been formed inside the nasal cavity. You are going to remove the crusting. There are a lot of options available for removing the crust. First one is G plus G. 25% glucose in glycerin. 25% glucose in glycerin. This can be used as a nasal douching, or combination of sodium bicarbonate, biborate, and sodium chloride. These are all used in combination to create a solution that can be used for nasal douching. So the idea is do nasal douching and clear the crusting inside the nasal cavity. So first we are trying with 25% glucose and glycerin, then combination of sodium bicarbonate, sodium biborate, and sodium chloride is BBC. In DDC, just remember it as vitamin D2. Then estradiol, not triol, estradiol. Then chlormycetin. Okay. So combination of these 3 components can also be used. Okay. For antibiotics, streptomycin can be tried. Okay. Vitamin D can be tried. So these antibiotics are given in oral or parenteral form. These are for nasal douching. Okay. So you start treating the patient with these strategies. Eventually the crusting will get reduced. If the crusting doesn't get reduced, will the patient know? The patient will not know. The typical thing is there will be anosmia for the patient, so that that very typical foul smelling odor will not be smelled by the patient himself. So this is called merciful anosmia. This is called merciful anosmia. The patient will be having merciful anosmia. So we should try medical management. If the medical management doesn't work for that particular patient, you should go for Young's procedure. Okay, Young's procedure. So it's a no-brainer. Why? You are getting infection inside the nasal cavity. It goes for atrophy. Something is entering into the nose, maybe air current or some water. It is having bacteria. That bacteria is creating atrophy. If this keeps on happening, the disease will not subside. So we can try simply by closing the nasal cavity. The surgery is pretty simple, that close both the nasal cavity by raising a flap. Okay, you are closing both the nasal cavities by raising the flap. You may ask, how can the patient breathe, doctor? See, in ENT, if you want to cure some disease, you don't have to worry about nasal breathing. Okay, ask the patient. Till that time, you are just by breathing through your oral cavity. Okay, the patient will breathe through the oral cavity. Both the nasal cavities are closed by raising the flap. That procedure is called Young's procedure. Clear? The patient will be very suffering after this procedure, but that's not the case. The symptomatic atrophic rhinitis is more cruel for the patient. No one will go near the patient. That will be the intensity of the foul smelling present in that particular patient. So the patient will be okay with this particular surgery because he or she will be hoping that the things will go better eventually. So same Young itself modified as you insert a small tube inside the nose. Okay, you insert small tube inside the nose and then you close the rest of the area. The small area is for breathing. Okay, so keeping a small tube and then closing the nasal cavity. It is called modified Young's procedure. It's called modified Young's procedure. Clear? So atrophic rhinitis, I'll revise. See, it is caused by Klebsiella ozane. The other name for atrophic rhinitis is ozane. Pathogenesis, you should remember the name as Zaufel. Presentation, greenish crusting, roomy nasal cavity, merciful anosmia. Medical management, you just remember it as G plus G, BBC, DDC. Then antibiotics, vitamins. Surgical management, Young's procedure or modified Young's procedure. Surgery where one nostril is partially or completely occluded is done for which condition? Atrophic rhinitis. See, if the patient says that I get cured only one nose at a time, you can give option for that patient. You could do surgery for one nose at a time, leave the other nose, then after 6 months, you do for the other nose. After 6 months, you open the operated nose, you do surgery for the other nose. Alternatively, if you do, you can also do like this. This is also Young's procedure. If you place the tube, it is modified Young's procedure. Okay, it's not mandated that you should close both the nose. You could close one side of the nose, leave the other nose, then you could do that nose after 6 months. Okay, so where one nostril is partially or completely operated is done for atrophic rhinitis. An important thing, foreign body inside the nose. These children play with a lot of things. That things will go either inside nose, oral cavity, ear, because they have this mannerism to put something inside the hole. Okay, so if they place a bead or a groundnut inside the nose, what will happen? The child will present with foul smelling, unilateral nasal discharge or epistaxis. Okay, foul smelling, unilateral nasal discharge or epistaxis. So if you see the foreign body, remove as early as possible. Remove as soon as possible. Okay, if a 10 years old comes to you, the mother or father did not give you a proper history about the foreign body inside the nose, you left it off. You are not removing the foreign body. Over the years, if the foreign body is not removed, it gets surrounded by chronic inflammatory debris. Okay, chronic inflammatory debris that will have some concretions. Okay, so the nucleus of this particular lesion will be the foreign body. Outside the foreign body, there will be chronic inflammatory reaction happening. So this is called rhinolith. Okay, a foreign body gradually turning out into a lesion. It is called rhinolith. So this will happen only in non-biodegradable foreign body. Okay, like example, stone. Stone can never be degraded by the nasal enzymes. Okay, so that's why the term lith has been given. Most of the times, stone unnoticed by over the adolescent age group. Then during the adult, you could see a stone-like thing over the nasal cavity due to unnoticed foreign body unremoved. Okay, so foreign body nose, rhinolith, very easy concept. You should remember. Clear? Then nasal meiosis. Okay, it is caused by chrysomia. Caused by chrysomia. It is nothing but larval forms of the flies. Larval forms of the flies. Okay, if there is unhygienic nasal cavity, there is unhygienic nasal cavity. This unhygienic nasal cavity will get the flies to lay eggs inside the nose. If such event happens, initially for 1 to 3 days, there will be slight nasal irritation. There will be slight nasal irritation. After 4 days, the patient will get an epistaxis episode. Then only the patient will come to the doctor. Then only diagnose the nasal meiosis. You have seen a nasal meiosis inside a unhygienic nasal cavity. First thing, maintain hygiene of the nose by giving nasal douching. By giving nasal douching, yeah, you've done that. Or else you should somehow attract those larvae outside the nasal cavity. How we are going to do that? You could use halothane. Halothane is an inhalational anesthetic. If you put the halothane inside the nose, this larval forms of the nasal meiosis will come out of the nose. Okay, or else you could also try chloroform. Okay, chloroform can also be tried. That will bring out the nasal meiosis out of the nasal cavity. Or you could do turpentine oil. I could use turpentine oil. Okay, so these are 4 miscellaneous conditions. I'll again revise. Atrophic rhinitis, Klebsiella hoseinae, merciful anosmia, Young's procedure. Foreign body of the nose, unilateral foul smelling nasal discharge with epistaxis, remove as soon as possible. Rhinolith, unremoved foreign body over a chronic period of time, you should do surgical excision. You should do surgical excision. Nasal meiosis, unhygienic nose, there are maggots inside the nose. Okay, so these are maggots. Okay, maggots inside the nose. These maggots will keep on reproducing and will create chaos inside the nasal cavity. So you should remove the maggots as early as possible by using halothane, by using chloroform, or by using turpentine oil. Okay, so 5 years old child coming with epistaxis and foul smelling discharge for 2 days, possible diagnosis is So epistaxis, foul smelling discharge. They didn't give the word unilateral, but no speaking, no foul smelling. Osler-Weber disease, only epistaxis. It's a hereditary hemorrhagic telangiectasia. Okay. Foreign body of the nose is the answer for this question. Maggots in the nasal cavity are commonly treated by chloroform diluted in water. Not liquid paraffin, not antibiotics, not lignocaine spray. Clear? Fine. Now, I'm going to introduce you to a picture mnemonic. What is that? RRR. See, in rhinology, you should never forget 3 R's. See, this is not Rajamouli's rise, roar, revolt. This is our rhinologies, Rhinosporidiosis, Rhinoscleroma, Rhinophyma. You may ask, sir, we have already come across a lot of rhinitis, then rhinolith. Why these 3 R's are very important? Because these 3 are MCQ wise very important. Then these 3 are not related to each other. These 3 have some distinctive features. If you understand the distinctive feature by remembering it as RRR, each R will be having some distinctive feature. You will never forget these concepts. So next time, if you think of RRR, these 3 things should come to your mind: Rhinosporidiosis, Rhinoscleroma, Rhinophyma. Okay, we are just going to deal these 3 things. What is Rhinosporidiosis? Just remember, if you are from the village, what you will do? What you will do? You always bathe inside ponds or river. Okay. So while doing so, the water will be unhygienic. Why it is unhygienic? There will be cows bathing inside. There will be buffaloes bathing inside that pond. But still, this young kid is swimming inside that pond. Okay. So the cow dung of the pond will be carrying an organism called Rhinosporidium seaberi. Rhinosporidium seaberi. Clear? So the Rhinosporidium seaberi will be present in the cow dung. Okay. So if the child still swims inside the water unknowingly, what will happen? This spores of the Rhinosporidium seaberi will enter into the nostrils. Will enter into the nostrils. Okay. The spores of the Rhinosporidium seaberi will enter into the nostrils of the young kids. What will happen? Over a period of a chronic period, around 5 to 10 years, the spores will grow inside the nasal cavity. Will grow inside the nasal cavity. So when growing over a longer period of time, it is called rhinosporidiosis. So what is the presenting feature of rhinosporidiosis? This is pinkish friable mass that bleeds on touch. See, polyp will not bleed on touch. Here, it will bleed on touch. Okay, it bleeds on touch. The surface will have spores. The surface will have spores. Okay, surface will be having spores over them. Fine. So, if you encounter such patient, what will you do? First thing is, you explain it to that particular patient that always recurrence happen. There is no surgeon born in this world to assure the patient that you will not get this rhinosporidiosis again, because it will always recur. It will always recur. Okay, so what shall we do? But still you have to do surgery. What surgery? You should do excision of the mass with cauterization of the base. With cauterization of the base. Excision of the mass with cauterization of the base. Okay. Is there any medical management that is possible? Medically, you could give tablet dapsone that will reduce the growing potential of the lesion, but it is not curative. So dapsone 50 milligram can be used as a treatment for rhinosporidiosis. Another important thing. So this rhinosporidiosis previously thought to be fungus, then it is thought to be protozoa. Finally, it is confirmed as aquatic protozoa. Okay, it's thought as aquatic protozoa. Clear? Right. Then the life cycle of the rhinosporidiosis is very, very important. So what is the life cycle? First, it will start with endospore, then it will grow into trophozoite, then intermediate sporangium, then mature sporangium. Okay, then the mature sporangium will be 200 to 250 micron in size. 200 to 250 micron in size. Then finally it will burst out to release the endospores. It will burst out to release the endospores. First, endospore, trophocyte, intermediate sporangium, mature sporangium, then finally it will burst down. So, what is the classification? Rhinosporidium seabury is now classified as aquatic protista protozoa. Aquatic protista protozoa. Clear? Yes. Now, medical management we have seen dapsone. Surgical management we could do excision and cauterization of the base. Now, we can enter into the next disease, rhinoscleroma. Second R. RRR, second R. Klebsiella rhinoscleromatis. Klebsiella rhinoscleromatis. Okay. So this Klebsiella rhinoscleromatis has 3 stages: atrophic, granulomatous, psychiatric. So it is nothing but a bacterial infection that is happening inside the nasal cavity. This bacterial infection first will cause atrophic rhinitis filled with crusting inside nasal cavity. Atrophic rhinitis filled with crusting inside the nasal cavity. Gradually, this atrophy of the nasal cavity will turn down to granulomatous lesion. Granulomatous lesion. This is called Hebra-nose deformity. Is called Hebra-nose deformity. Clear? First, there is atrophy of the nasal turbinates together with crusting and nasal discharge. Then there will be granulomatous lesion happening. It is called Hebra-nose deformity. It is due to subdermal infiltration. Subdermal infiltration of lymphocytes. Then it will go for scarring. The granuloma will go for scarring. This is called psychiatrial stage. The psychiatrial stage is characterized by tapir nose deformity. The nose will be very big. Okay. So woody nose. Woody nose. Okay. It is psychiatrial stage. The next stage is histopathological examination. You should remember 2 things. Okay. Miculic cell. Okay. So Miculic cell is nothing but vacuolated cytoplasm. Vacuolated cytoplasm with peripheral nucleoli. Okay, so Mikulic cell is an important feature of rhinoscleroma. Russell bodies is an inclusion body with bacteria. It will carry the bacteria. This is the Russell body. So these two are the important diagnostic confirmatory points of rhinoscleroma: Mikulic cells and then Russell bodies. Clear? What is the treatment for rhinoscleroma? Again, streptomycin and then rifampicin. Streptomycin and then rifampicin. So these are the treatment strategies for rhinoscleroma. I'll come again. See, rhinoscleroma is caused by a bacteria called Klebsiella rhinoscleromatis. It has 3 stages: atrophic, granulomatous, and then cicatrial. Clear? The atrophic will have crusting, granulomatous will have hebra-nose deformity, cicatrial will have tapered-nose deformity, woody inconsistency. Histopathology shows Mikulic cells and Russell bodies. Treatment with antibiotics as it is a bacteria causing the disease. Streptomycin and rifampicin. Then fish bacillus. Okay, Klebsiella rhinoscleromatis has another name called fish bacillus. Klebsiella rhinoscleromatis has another name called fish bacillus. You kindly make note of it. So it is a causative agent for rhinoscleroma. So second are done and dusted. First are Rhinosporidiosis. Rhinosporidium is a protozoa. Rhinoscleroma is a bacterial caused infection. Now rhinophyma is not caused by any organism. It is not caused by any organism. Okay, it is nothing but hypertrophy of sebaceous glands. Hypertrophy of sebaceous glands that is happening. So it always coexists with the patients having acne rosacea. Okay, so it is an external lesion. It has nothing to do with the interior of the nasal cavity. So it always coexists with acne rosacea. Hypertrophy of the sebaceous glands or the external nose cause rhinophyma, otherwise called potato tumor. Potato. Okay, it's called potato tumor. Clear? Treatment: excision with CO2 laser. Okay, if there is a larger defect that is happening, you should use a graft in place. You should use a graft in place. Clear? Treatment of rhinophyma: exists the lesion with CO2 laser, then replace it with the skin graft. The disease that is associated with rhinophyma is acne rosacea. Okay, acne rosacea. Now for this thing, okay, I hope around 230 people are there. Okay, so it's quite late in the night. We'll play a game. Okay, we'll play a game. So this is a famous game you are all very fond of during your MBBS period. I know you would have played this game frequently. Okay, now you can, if the chat box, yeah, the chat box is open. I hope chat box is open. I'll project the image. Okay, I'll project the image. It's nothing but connection. Okay, so something that is relevant to the systematic disease causing nasal inflammation has been projected here. Okay, I'll project this. If you know the answer for that particular thing, you can come away. Okay, fine. So these are the 5 images. These are the 5 images. Anyone get to know about these images? So the chronic inflammation caused by systematic diseases has already been projected. Number 5 is cocaine addiction. Okay. Cocaine addiction, nasal perforation. Yeah. Then number 1. Number 2, Young's procedure. 2, atrophic rhinitis. See. These 5 diseases I didn't discuss yet. I have just told you the names. So I'll tell the names. Okay. Vaginal granulomatosis, Church-Strauss syndrome, sarcoidosis, NK cell lymphoma. These are your 4 options. One you have already found out, that is cocaine-induced addiction. Vaginal granulomatosis, Church-Strauss. Okay. NK cell lymphoma. No, pansystemic sarcoid. No, that's not an answer. Sarcoidosis. So these are your 4 options. Okay. So first one is some loop is happening. Okay. Second one is famous Voldemort character of Harry Potter. Here 2 things are there. Can, then card. Here pan card. Okay. Anyone? Any guesses? Loop, Voldemort. See, 3 is Church-Strauss. P and K. Yeah, that was a great attempt. Great attempt. First one is sarcoidosis. Yes. Can you tell why, Hemlata? Why you are telling first one is sarcoidosis? Why? What is the meaning of this loop? Anyone? Hemlata? Okay. So someone has answered. No, not lymphadenopathy. Pan card, P and K. Okay. So P and K. Clear? P and K will cause Church-Strauss. C. So obviously this will be, if this is P and K, this is C and K. Can, card, C and K. Okay. C and K. It is seen in vaginous. Okay. Now I left with only 1. Why I have projected Voldemort photo here? Anyone? Anyone? Why I have projected Voldemort photo here? Now, not erythematodeism. The diagnosis of this condition is NK cell lymphoma. Yeah, distortion of the nose. Not exact. Yeah, near. I'll tell how. So this is the last slide for this day. We are going to end this class. NK cell lymphoma is the most important disease that we are going to discuss. NK cell lymphoma is nothing but Stewart granuloma or midline lethal granuloma. Okay, Stewart granuloma or midline lethal granuloma, where there will be inflammatory destroy happening all around the bones and cartilage of midline. Okay, bones and cartilages of midline. The important diagnostic immunohistochemistry is CD56, CD2 and CD3 positive. Out of these 3, CD56 is more sensitive and more specific. Okay, it is caused by Epstein-Barr virus. Epstein-Barr virus. NK cell lymphoma caused by Epstein-Barr virus. CD56 midline lethal granuloma is an important systematic disease causing nasal inflammation. So we start with sarcoidosis. Lupus pernio. Okay, strawberry skin appearance. In nose, you will be having nasal perforation. You'll be having nasal perforation. Clear? Sarcoidosis will cause septal perforation. So these are systematic features of sarcoidosis. The local feature concerned with rhinology is nasal perforation. Vaginous granulomatous, you all know very well. Strawberry gums. Strawberry gums is an important feature of vaginous. Vaginous will affect the nose, airway, and then kidneys. Okay. So in nose, still you will be having some nasal perforation. Nasal perforation together with pulmonary infiltrates and then CKD. So if this triad happens, if these two options are given, if they ask for nose lesion, you should look for nasal perforation. Clear? In chalk straws, again a triad where paranasal sinuses, lung having bronchial asthma. Okay, these two will be the main lesion happening in chalk straw syndrome. In PNS, sinusitis, lung asthmatic. Okay, so chalk straws, P and K. Vaginous, C and K. Okay, chalk straws, P and K. Vaginous, C and K. Okay, last thing, cocaine addiction. Okay, the Arjun Reddy movie reference was given over here. If you keep on snuffing this cocaine into the nose, it will, what is cocaine? Cocaine is an autonomic drug. It will increase the vasculature over a period of time and finally will cause nasal perforation. Okay, nasal perforation. These diseases can be given in the form of a bigger question. So you should be aware of what nose symptom they are causing. Sarcoidosis, nasal perforation. Vaginous, nasal perforation. Chalk straws, sinusitis, that is a different one. NK cell lymphoma, destroying all the midline structures. Cocaine addiction, nasal perforation. So that completes our discussion. First, we started with acute inflammation. Acute rhinitis, viral coryza. Allergic rhinitis is due to type 1 hypersensitivity reaction. Vasomotor rhinitis is due to emotions. Done, understood. Then chronic inflammation, local, hypertrophic rhinitis, rhinitis sicca, rhinitis caseosa, rhinitis medicamentosa. So rhinitis medicamentosa, you should stop using oxymetazoline, xylometazoline, which is a nasal decongestion. Then we saw about rhinosporidiosis, rhinoscleroma, rhinophyma. 3R. Okay. Rhinosporidiosis caused by protozoa. Rhinoscleroma caused by bacteria. You will be having Hebra nose deformity, tapir nose deformity, rhinophyma. It is not caused by organism. It is a hypertrophy of the sebaceous glands over the nose. So it is rhinophyma, potato tumor, comes with acne rosacea. 3 R's. Then we discuss this beautiful connection question where we discuss the systematic causes, sarcoidosis, vaginous granulomatosis, chalk straws, NK cell lymphoma, cocaine addiction. If you have any doubts, you can kindly pour in your doubts. Okay, I hope it was a useful session. Again revising the same stuff that you have already took note of it. I thought it will not work, so I added so many important points. Okay, next page questions. Yeah. Okay. Strawberry appearance of nasal mucosa is seen. Strawberry appearance of nasal mucosa is seen. See, strawberry gums, vaginous. Okay. Strawberry skin is sarcoidosis. Okay. So the answer could be sarcoidosis. If the option has strawberry gums, means you could write it as vaginous granulomatosis. True about T-cell lymphoma. It was an old pattern PGA question. Association with Epstein-Barr virus, nasal obstruction epistaxis. Cell expressed T cell marker, locally invasive, all the above. So all the above is the answer for this T cell lymphoma. I hope it would have help yourself to a greater extent. If you have any doubts, you can ask me. Okay, fine. See, this question. See, strawberry appearance of nasal mucosa. So if you want to answer this as rhinosporidiosis, you need still more points. Strawberry appearance of nasal mucosa, yeah. Is the nasal mucosa appearing strawberry like? No. Another lesion is forming inside the nasal cavity. Okay, another lesion. Sarcoidosis. Sarcoidosis is an auto-inflammatory disorder caused affecting all over the body. So you'll be having hilar lymphadenopathy. So mainly it is an auto-inflammatory disorder affecting the entire body, especially hilar lymph nodes will be affected. In nose, nasal perforation will be the feature. What is the diagnostic test that you could do for sarcoidosis? Quaim test. You could do a Quaim test. Okay. So I'm telling just because you asked it. Okay. Sarcoidosis, nothing but an inflammatory disorder. It is happening all around. Septal perforation, bony or membranous in cocaine addiction, sir. That was a good question. See, in septal perforation of cocaine addiction, it is cartilaginous. I'll tell you the concept. See, this is the nasal septum. Okay. This is the cartilaginous part of the nasal septum. This is the bony part of the nasal septum. You can't easily erode this bony part of the nasal septum. It will be very hot. It will have blood supply from the sphenoid above, maxilla below. But this cartilaginous portion of the nasal septum will be having vasculature only from the perichondrium. Only from the perichondrium. So when you keep on sniffing cocaine, it will irritate the nasal mucosa first, then it will irritate the perichondrium. Once it irritates the perichondrium, it will disrupt the blood supply of the nasal septum. Eventually, it will cause perforation of the cartilaginous part of the nasal septum. I hope it is clear. Who asked this question? Okay. Church-Strauss nasal finding. See, Church-Strauss nothing but a typical disease where you'll be having all involvement of the lungs having asthmatic bees. Okay. Paranasal sinuses will be having sinusitis. See here, there will not be any perforation. There will be sinusitis with nasal discharge. Okay. Rhinitis sicca and rhinitis gaseosa. Okay. See, rhinitis sicca, as of I know, dry currents will cause rhinitis sicca. That is the only point that has been given even in Dhingra book. Okay, I've searched all the books. There is that disease was present over the literature only. Okay, it is not common nowadays. So no good description is given in recent books and all, recent editions and all. So if they ask rhinitis sicca, they will ask that rhinitis sicca dry occurrence. If a cheesy material comes as a nasal discharge, it is rhinitis gaseosa. The cause, exact cause for rhinitis sicca is living in a dry place. For gaseosa, the exact cause is unknown. For treatment for these two is you could do a nasal douching. Okay. Okay. So the cocaine addiction is causing. So it's cut down the blood supply of the nasal septum. Okay. So it is an autonomic drug. First of all, it's an autonomic drug. It causes vasoconstriction. Okay. So once it causes vasoconstriction, then eventually it will cut down the blood supply of the nasal septum. Then it will cause nasal perforation. Okay. Any more doubts? Thank you, Mr. Kalam. Thank you. Thank you, Monica. Thank you, Batma. Thank you, Dr. Bharati. Thank you, Pavitra. Thank you, Shanmugam. Thank you, thank you. Thank you, Ayushman.